Well, first I'd like to thank all of you guys for coming out on this beautiful day. It's a relatively small group today, and it's a small room, so if you guys have any questions, please, you can holler them at me and we'll try and answer them as we go along. I don't mind. I don't have that many slides, so we'll just go through. I wanted to tell you a little bit about myself. I joined the Springfield Clinic in September of 2013, which is a little bit beyond 6 months now. And I did my training at the New York University, NYU. I was also at University of Chicago for a little bit. I was at State University of New York and the University of Colorado. The State University of New York, Brooklyn. So a lot of time in New York City, and then Chicago, and then Denver, so a lot of different places. So, and I've been really enjoying Springfield. My wife is from around this area, and I gotta say, it's a very beautiful part of the country. The winter was tough, but I guess that makes you tougher, right? So let's get on with the talk here. There we go. So we're talking about age-related macular degeneration today, a closer look. And so it's a large problem. 15 million people across the North Americans have age-related macular degeneration. So it's a large group of people. It's also the leading cause of severe central vision loss in the people over the age of 50. So it's a major burden. Risk factors for macular degeneration include positive family history, cigarette smoking, lighter iris color, hypertension, hypercholesterolemia, and female gender. So there are a lot of people affected by this disease, and the thing about it is the central acuity is the acuity that you use to read, to look at faces. That's the acuity that's lost in macular degeneration. The peripheral vision typically stays even in advanced macular degeneration, except in rare instances with large hemorrhages. But in general, it's the central vision that's affected. There are two types of macular degeneration. One is dry age-related macular degeneration, and another term for that is non-exudative. And that refers to atrophy of the retina and appearance of drusen, which are small yellow round lesions underlying the retina. And then there's the wet form, and sometimes we just call it dry or wet macular. The wet form has a worse prognosis and refers to bleeding underlying the retinal or intraretinal surface and or subretinal fluid. So I wanted to show you guys this picture because this is, some of you may come for eye exams. This is what we're looking at when we see dry age-related macular degeneration. This is the optic nerve. These are the vessels that emanate from the nerve. They're both arterial and venous vessels that come from the nerve. The thicker ones are venous vessels. And these little spots here, these are the drusen in the back of the eye. This area here centrally is an area of atrophy. And these are the end result of macular degeneration. It's not the drusen that cause visual loss, it's the atrophy. Atrophy is loss of tissue. It's the loss of the retinal tissue that causes the visual loss. Unfortunately, with macular degeneration, the area that's lost is the area right in the center where the central acuity is. And this is the end stage of both dry and wet macular degeneration. The thing that causes visual loss in both is the atrophy of tissue or the loss of functioning nerve tissue. So is there a treatment for the condition? So that's a great question. The best guidance for treatment currently is the use of the AMD vitamins. Now, some of you may have macular degeneration. Some of you may know people who have macular degeneration. And the eye vitamins are an important part in preventing progression of the disease. A new study came out, AREDS2, that was recent, in 2013. And what they basically found was they're both as efficacious. AREDS and AREDS2 are both equally efficacious, but the difference is AREDS2 is a little bit safer for patients who were or are current smokers. The other part that we see here is the Amsler grid. This is the thing that we ask patients to monitor and to check with one eye at a time to ensure there's no progression of disease. And what we're looking for is when one eye is covered, sometimes there can be distortion of these straight perpendicular lines. And that can happen with either progression of the dry form or if it's converting to wet. And that's why you're asked, or some are asked to look at these grids, because that's what can give us a tip-off. Usually we follow our dry macular degeneration patients at once every 6 months. And without this, it's kind of a very basic and arcane test, but without this basic test, we may miss patients who convert to wet. And so why is that important? Well, it's important to figure out if somebody's turning to wet because there's actually treatment for wet macular degeneration. So I was talking a little bit about the eye vitamins earlier. This is kind of the AREDS2 composition. And it has vitamin C, vitamin E, zinc, copper, lutein, and zeaxanthine. Now, the difference between the AREDS2 composition versus the AREDS1 composition is essentially beta-carotene. Beta-carotene was part of the original AREDS supplement, and it's a carotenoid, and the issue with beta-carotene is that it's been linked with a small increase in the incidence of lung cancer in patients who are smokers or former smokers. And that's why it makes it a little bit easier for us to, recommend AREDS2 because it does not have that beta-carotene. And so that's part of the reason why they did the AREDS2 study. They wanted to take a look as if they removed the beta-carotene from the supplement and replaced it with lutein and zeaxanthine, would they get the same effect in terms of protection for progression of age-related macular degeneration? And they did. And that's why the newer supplement has lutein and zeaxanthine. Now, if you are a patient who's on the current, or if you know somebody, or if you are a patient who's on the current formulation or the older formulation with beta-carotene, if they're not a smoker or former smoker, then there's not necessarily a reason to switch. Okay? But those are the components that are a part of the AREDS2 formula. So I sometimes get this question in my office. My friend or family member does not have macular degeneration. Should they take an AREDS or AREDS2 vitamin to reduce their risk of macular degeneration because both their parents had macular degeneration or, et cetera? And the short answer is no. If they don't have macular degeneration, they don't need to take the AREDS vitamin. The best advice is to maintain a diet rich in spinach and fish, the green leafy vegetables, and a multivitamin. And that way, that will reduce the risk of a lot of different things, but also oxidative stress on the retina. And we talked about that. So there are a couple of genetic tests out there, and so I've gotten the occasional patient who will ask me, should we get a genetic test because my parents had macular degeneration or I have early macular degeneration? I want to know about my risk of developing wet macular degeneration. And there's a certain part of you that would like to know, but the real answer is, and what I tell my patients is, it's not really necessary at this point. There are tests out there that can tell you if you're at increased risk for developing wet macular degeneration, but at this point we're not doing anything differently. We would just continue using the same AREDS vitamin and continue telling you to monitor the Amsler grid, and we wouldn't change anything else except we'd make you worried that you have an 84% risk of developing wet macular degeneration in the next 10 to 15 years. So I don't think that really gets anybody anywhere. If there was a treatment we could offer you because of the results of the genetic test, then yes, I think it would be useful. And that may soon change, but my stance is the same as the stance of the American Academy of Ophthalmology, which does not support routine genetic testing of patients at present for this disease. But there are, and you should know, there are two tests that are on the market: Macular Risk NXG by Arctic RDX and Retina Gene AMD by Sequenome, that are currently available for genetic tests for the progression of macular degeneration. So this is where it gets interesting. There are some trials out there. Actually, a phase 3 trial. This Mahalo trial was completed. It was a phase 2 trial. But the phase 3 trial is of a drug called lampalizumab, and the trade name is actually going to be Fovista. And it showed a reduction in the amount of atrophy. And remember, I talked to you about atrophy leading to visual loss in macular degeneration. It showed a reduction in the amount of atrophy in patients treated by about 20%. And in some specific subcategories, 40%. Well, they found these patients in the specific subcategories by doing genetic testing. So I think in the future, genetic testing may play an important role in the treatment of macular degeneration. It's just not there yet. Once we have a treatment potentially like this one that's on the market and it's completed phase 3 trials, and we can select patients who would be benefit to be treated with this, then it makes sense to genetically test patients and get them on a specific drug that works for them. The other question we sometimes get is stem cell transplants. Is that being done? Stem cell transplantation is being done in lots of different parts of medicine. There are some very early trials for dry macular degeneration. And I've seen some of the results for these trials. And really, they're just looking at patient safety currently. It's not really looking at returning vision as of yet. It's a phase 1 trial. And that's where they're at with it. So it's very preliminary, and that's really all they're assessing is safety. So it's pretty far off in terms of stem cell transplants. The other type of macular degeneration is wet or neovascular macular degeneration. Here's another picture. Here we see the optic nerve again. Here are the vessels that emanate from the nerve. And this large area here is central hemorrhage. And this is a big part of wet macular degeneration. Now, a lot of times the end result of all this is atrophy, but in the interim, what we're treating for patients with wet macular degeneration is the bleeding in the back of the eye and the fluid in the back of the eye that is produced by these abnormal membranes that form as part of the disease process. And so prior to 2006 was a big year. In 2006, we didn't, if you were in 2004, if you had wet macular degeneration, we did laser and a thing that they call cold laser that we don't really use that often anymore, or PDT laser. But then down at the University of Miami, they started to do intravitreal injections, or injections in eyes of drugs that can help clear up this hemorrhage in the back of the eye. And that was just started in 2006, and it has been a vision saver for many, many patients. Because just this hemorrhage and the fluid can reduce vision significantly and very quickly. That's what a lot of our treatments and therapies are today. At present, there are 2 widely used drugs that are commercially available for on-label use. One is Eylea, developed by Regeneron, and the actual name is aflibercept, and the second is Lucentis, developed by Genentech, and the trade name is ranibizumab. These are the majority of drugs that I use for patients with macular degeneration in my clinic. There's a third drug, Avastin, also made by Genentech, but it's an off-label indication for the use. They haven't actually sought FDA approval for it. And because of that, it goes through a compounding pharmacy. So I don't use that one that much. I do use it sometimes. And what the trials showed that for patients with macular degeneration, or the wet form of macular degeneration, who received Lucentis, they showed a large amount of visual improvement in patients who were treated. And then they showed about 40% of patients had about a gain of about 6.5 letters at about a year's time with these drugs. And that's amazing, because prior to this, the way people were looking at these treatments and therapies for macular degeneration was how much vision was lost. So it was a shift in the way we actually started looking at our medications. We were looking at how many lines of vision were gained versus how many lines of vision were lost over time. So that was the real paradigm shift in the treatment of macular degeneration, and that happened back in 2006. Here's an image, an OCT image, of a patient with macular degeneration, and this is the neovascular membrane, or the area that bled in kind of cross-section. It's an OCT image, and you see there's fluid and this irregular shape of the retina. This is after treatment with Lucentis. The contour is much improved in the retina, and the intraretinal fluid that was quite apparent is gone. And this is the same patient. So this is what the drugs can do. There are a couple downsides to these drugs. The first is, with any kind of injection we do in the eye, there's always a very small risk of infection. The risk is about 1 in 1,000. The second is they require ongoing treatment. The holy grail is if one of the drug companies is able to develop a depot injection where you inject once and the effect is found for months or years. But that's not there yet, and these drugs only are in the eye for about a month's time. That's why patients often require multiple or a series of injections that are spaced out monthly or bi-monthly. And the third downside is these anti-Vegf or vascular endothelial growth factor, Lucentis, Eylea, they also have a slight increase in the risk of stroke for patients. It's a very small increase. It could be associated with the groups that are getting these drugs because they already have other risk factors for stroke in terms of aging, hypertension, and those kind of things. But they have documented a slight increase in the risk of stroke in the patients who are treated with these drugs. So future therapies for wet macular degeneration, there are multiple new drugs in the pipeline. Up until present, most of the targets for these drugs is a hormone that's produced in the eye called vascular endothelial growth factor. They are actually looking at new targets and new areas to kind of select. And again, one of the ones we were talking about was Fovista. And that has a new target. It's anti-platelet-derived growth factor. And it's actually in stage 3 trials now. But in the stage 2 trials, what they did was they injected it with Lucentis. And they found that patients who were injected with both drugs gained 11.5 lines versus 6.5 lines, or 11.5 letters versus 6.5 letters for patients treated with both drugs versus just Lucentis alone. So it could hold a lot of promise, but it's still an injection, and that there's still downsides to the injections that are with all those injections we just talked about. So that's really all I got. Go ahead, please. For injections, in general, so there's the risk of infection, there's the need for ongoing therapy, so monthly or bi-monthly or once every whatever it is. And then the third is that there's a slight increase in the risk of stroke or cardiovascular accident. And it's a very small increase, but it is there. But that may, and it doesn't matter who you get it from or where you got it or whatever else, but there's a slight increase. That has been shown across multiple trials, but it's only like a fraction of a percentage point, but that's there. And the reason for that is that even though we just inject it in the eye, a small amount of drug will go systemically. Systemic. It'll be absorbed by your whole body. Yeah. Yeah. Does anybody else have any questions? Because I'm kind of through with it. Go ahead. So the question was, what's the difference between Lucentis and Eylea for anybody who may not have heard? So Lucentis, the target, it's an antibody, and it's a fraction of an antibody, and the antibody is to vascular endothelial growth factor. And so that was developed in 2006. Eylea is it's a decoy receptor. It's a protein that looks like where the VEGF should bind. It's not an antibody. It looks like the receptor. So it has a few more targets. There are a few more other things that can bind to the receptor than just vascular endothelial growth factor. So it gets a few more things, and it's also not an antibody. It looks like it's a protein that looks like the receptor of your own body that usually receives that hormone signal.
So that would be a reason
So that's a great question. Switching from Lucentis to Eylea, you can switch from Avastin to Lucentis, Lucentis to Eylea, Eylea back to Avastin, Eylea to Lucentis. The reason, there's a couple possible reasons to switch. One is sometimes the body gets resistant to a certain medication you're injecting. And so, you may have seen a large result the first time you injected and the second time, and you may be keeping the same interval, but then all of a sudden you stop seeing an effect. Or, the fluid gets worse and worse every time you come in. And that would be a reason to switch from one drug to another. The other reason that some people feel Eylea may be a little bit superior in some ways to Lucentis is that the way they did the trial for Eylea, they dosed patients once every 4 weeks for 3 doses, and then went out to once every 8 weeks. And they found that once every 8 weeks dosing in their trial, in the View 1 and View 2 trial, they found that once every 8-week dosing was equivalent to Lucentis dosed once every month. They found no difference in terms of that. Now that being said, in the real world, most people don't get Lucentis once every month. It's usually a little bit, they may start once every month, but a lot of times it gets out to every 6 weeks or every 8 weeks. And when they actually looked at the Medicare data and they went back and took a look at how often Lucentis and Eylea was used over the course of a year for the same diagnosis, the difference in the number of injections was about half an injection. So in reality, the dosing is very similar between the two. When we actually take it from the way they tell us to use it to the way it's actually being used, the dosing is very similar.
So it's like any other drug. Everybody's going to respond differently.
Everybody's going to respond differently, and sometimes people stop responding to a certain drug and start responding to another.
When you give the shot in the eye, which part of the eye do you put it in? The middle of the eye?
We usually do the shot to the eye in the infratemporal quadrant, about 3.5 mil. Well, let me cut back a little bit. It's in the white portion of the eye, about 3.5 millimeters posterior to the start of your cornea, or the limbus. Okay, go ahead.
I've been getting the shots every 28 days of Lucentis
Mm-hmm.
both eyes for about 3 years,
Mm-hmm.
and it's improved my sight.
Mm-hmm.
You think that will have to go on forever?
So the question is, I'll just repeat it for the group if that's okay. You know, a patient's been receiving bilateral injections once every month for the past 3 years, and she's asking, will it have to continue forever? So, I can't speak to your specific case, but in general, it's hard to stop the injections for a patient that we see a good response in for macular degeneration.
We tried the 6 weeks, and that didn't work.
So if you tried to extend out to 6 weeks and it didn't work and you went back to 4, then you may be on it for a while until something new or better comes along that can extend you out further.
I think my eyes water a lot. Is that one of the...
Side effects to it? So sometimes after an injection, the eyes can water just for that day or two because of the cleaning solution that we put in the eye, the betadine we put in the eye, can make the eye uncomfortable for the next couple days.
Well, I tried refresh tears, and that didn't help me very much, so I went to blink,
Mm-hmm.
and that seems to be a little stronger, and
That helped you.
does help me more.
Good.
But I love the sunshine, but my eyes don't. Way too bright for 'em.
Yep. Yep. Go ahead. Mm-hmm. Mm-hmm. Oh. Okay, so the question is about taking additional lutein to the AREDS vitamin. And so the question is basically, sometimes it can be hard to take both those doses of the AREDS 2 vitamin. The truth is, what's been looked at is what's in that group of those numbers I showed you up earlier. So the lutein dose, let's go back to it because I can't remember, to be honest with you, off the top of my head what exactly that. It's 10 to 20 milligrams of lutein. And so in terms of what a patient should be getting, it's really what was in the study, because that's what was looked at. So if you take a higher or lower dose, you may get more or less of an effect, but to be honest, I don't think anybody can give you a real answer to the question. So what I recommend taking is exactly was in the pill that showed to reduce the risk of progression. No, you should be getting exactly like the lutein and everything. You should be basically getting, if you're getting this in whatever form you're getting it, that's what you should be taking. No. No, you don't need A. Yeah. Yeah. Not necessarily. I mean, you don't want to overdose on the lutein. So if you're supplementing above the 10 to 20 milligrams, there's none in there. Yeah, then it's fine. Then you're just taking A separately, then it's different. But it's not going to be harmful as long as you're not going over what these doses are on a daily basis. And what's your second question? Mm-hmm. Okay, so the question was, does glare from the computer have any effect or damage to the eye in macular degeneration or otherwise? The short answer is no. The glare will not be damaging to your eye in general, and it's not any more damaging than looking at anything else. Go ahead.
If you're taking AREDS 2 twice a day,
Mm-hmm.
would a multivitamin help too? Take a daily multivitamin?
So a daily multivitamin in addition would be okay. Okay, it's nothing that you have to do, but this obviously doesn't cover everything that a daily multivitamin has. So taking a daily multivitamin, the best would be is if they made a daily multivitamin with these components in it, but that may or may not exist. And there's so many different options, I know, because I go to the grocery store too. All the different options when you go to that aisle, it's, you're almost paralyzed by the amount of choice. Yeah. Go ahead.
One of the things to eat is fish.
Mm-hmm.
What about fish oil?
So that's a great question. Fish oil was looked at in the AREDS 2, or at least they looked at omega-3. So they didn't look at fish oil, but omega-3, which is found in there. And they did not find any higher risk, any higher protection from the omega-3 supplementation in macular degeneration. Now that being said, it's already been established that omega-3 is protective for heart attack and stroke. So I wouldn't tell you, I think it's a good thing to supplement with, but it's not part of this.
Another question. We have a friend who gets the shots once a month.
Mm-hmm.
And she goes to Texas for the winter for 5 months. When she's down there, she has to take an antibiotic for 3 days before her shot.
Mm-hmm.
But here she doesn't.
So that's a good question. So there's a little bit of voodoo involved in all this. So some people may do a little rain dance before. No, the thing is, the question of antibiotics has been looked at, and in terms of treatment of it with antibiotic, they've shown that it's not necessary. The patients develop the same rate of endophthalmitis or infection in the eye with or without the antibiotic. That being said, there are certain practitioners who will always use the antibiotic and some practitioners who don't use the antibiotic. What I personally do is I don't have the patient take an antibiotic 3 days before, but I do put a drop of antibiotic in my office at the end of the injection. Now you could ask me why I did that, and I just say, because that's the way I do it. But there's no real evidence to tell me that I should or should not do that, but I do. And I just put 1 drop in. So it is what it is. It's just one of the things that there are a little bit of variation between practitioners, but overall, the antibiotics have not been shown to be of benefit either pre or post injection. So that's where we're at.
Macular degeneration in one eye, are you most likely susceptible to getting it in the other eye too?
So the question is, if you have macular degeneration in one eye, are you susceptible to it in the other? The short answer is yes. It depends on what types of macular degeneration you have. A lot of times patients have dry macular degeneration and dry macular degeneration in both eyes. Now, there are some patients who develop wet macular degeneration in one eye and have dry in the other. For those patients, I always recommend, I really insist that they take the AREDS vitamin, because that's definitely been shown in their case, in that specific instance, to lower the rate of conversion from dry to wet in the eye that's not affected. But there is a risk of conversion from dry to wet. Go ahead. So the question was, they had a friend who was 60 who's now blind in one eye, who they said had macular degeneration and was due to stress. From the story, it sounds like it's probably what we would call central serous chorioretinopathy, which is a form of macular degeneration, but it's not the same macular degeneration as what we're talking about here. Now, but the thing is that there is some overlap between what they call chronic central serous chororetinopathy, and wet macular degeneration. So that there is an overlap between the two, but the majority of they're usually separate, and typically central serous in most cases, or what your friend probably had, is usually self-limiting and usually resolves by itself with very little damage. It's when it comes back multiple times is when damage can accumulate, and those unfortunate patients there can be, and they can lose central acuity if it's been going on for years. It usually starts in the 40s and can go up into the 60s. So that's probably what she had. It's not exactly this, though. It can. I mean, that's the reason why we're always hesitant to take a patient off injections completely. There have been some patients who can, once taken off injections, can have a bleed and rapid visual decline, especially if it's central. So that's kind of the, I always, in my practice, if a patient doesn't want injections, I'm not going to give them injections. Because ultimately, it's the patient's choice if they want injections or if they don't want injections. At the end of the day, it's their body, it's their decision. They're adults. As long as they know what the risks are, if they know what they want to do, then I'm not going to stop them from doing it. But there is that risk if you suddenly stop taking injections and you've been taking on injections on a very kind of regular cycle that you could have an event in the eye that you stop taking the injections in.
My mother's brother had macular degeneration and went blind in both eyes. What is my risk factor?
So your risk factors for macular degeneration are basically that a family member has had it. If you go back to our other slide here, you're also maybe lighter pigmented, and the question of cigarette smoking. I mean, you have one of those risk factors, but as you can see, it's a multifactorial disease. There are multiple different other things that can increase your risk or decrease your risk. So it's not one of those things where you can say, my mother and father had macular degeneration, am I going to get it? The answer is maybe, maybe not. We don't have the, we can't tell you for sure. Now, you could do a genetic test like we talked about. There are genetic tests out there that can kind of take a look at, they look at complement factors, and they can take a look at the complement factors that you have, and they could probably do a risk estimate. But the real question is, why would you want to know if there's nothing we can do about it? Yeah, quite, yep. Not necessarily, no. The short answer is no. Yep.
We've heard that your body can absorb so much vitamins,
Mm-hmm.
plus off the rest. These big quantities of vitamins. Does every body absorb all those?
They probably don't. They probably don't, especially vitamin C. Especially vitamin C, they probably don't absorb the full dose of vitamin C. But having said that, again, this is what the study was done on, and so I wouldn't recommend a lower dose of vitamin C. I'd recommend what the actual pill was that was used in the study, and this is what they used.
With the macular, is glaucoma also a risk?
No, it's not. Glaucoma is not a specific risk for developing macular degeneration or for progression or for protective. It's neither. It's a different entity.
I'm being tested for that now because my father had it.
Glaucoma is hereditary.
Yeah.
So that can be part of the reason why they would test you if a family member had glaucoma. But it doesn't have to do specifically with macular degeneration. Go ahead.
A friend yesterday said that she has the dry.
Mm-hmm.
She said, so I'll never go blind. And she said, but my husband has the wet. And then somebody interrupted me, never did get back to it, but that kind of left me.
So in a way, she's right. She has the dry and the wet. You never really do go completely blind with either.
Has the dry, her husband has the wet.
Yeah, but with the dry form in general, you won't go completely blind, and even with the wet form, you won't go completely blind. The peripheral vision will be intact. The end stage of both diseases ends up being atrophy. Now, atrophy is loss of the functional tissue, which I think we had a picture of over here. It's right there, right in the center there, that's atrophy. So, but what you see is the rest of this is all healthy. All the rest of this is healthy. So, in effect, is this patient blind? I can tell you no, the patient's not blind. Their peripheral vision is intact. They can ambulate probably around a room. Would they be able to read the paper? Maybe, probably not. Maybe not without a assisted reading device, if you understand what I'm saying. So the end result is atrophy central, but the peripheral vision is usually intact. Now, that being said, also, there's some patients that we follow for years with the form of what we call dry macular degeneration that never really develop this kind of atrophy. They just have these little specks in the back of the eye. And those patients with those specks without the atrophy a lot of times have very good vision. So if she hasn't yet formed the atrophy and she just has these specks, she could have actually very good central acuity for a long, long time. Because this is the end stage of the disease. And a lot of people never actually get here. They never actually get the atrophy. They just have the specks in the back of the eye. Now, with the wet macular degeneration, I have a patient who I injected today who has 20/20 vision in the eye, and she's doing fine. I see her once a month, and she's doing great. And she's still 20/20 vision. She's got better vision than another person with dry. So even with the wet form, patients can retain good vision for long periods of time. Now, yeah. Go ahead.
Is there any relationship with cataracts?
So that's a good question. Is there any relationship between cataracts and macular degeneration? There was some thought that cataracts could be protective against advancing macular degeneration because the cataract itself, because the lens wasn't clear, it was kind of cloudy, would block some of the UV light getting to the back of the eye. And they felt that the cataract could possibly be protective. And so they did some studies about patients who took out the cataract or left the cataract in and if their macular degeneration progressed or not. And they were kind of equivocal. There was some slight risk of progression, but then there was such a huge benefit from taking the cataract out in terms of vision. It was kind of a wash. And so, I don't tell my patients not to get their cataracts out to be protective against macular degeneration. And in fact, I think it's helpful to get the cataracts out because then the patients get their peripheral vision restored, which could be blocked by that cataract. Go ahead. I think an eye care specialist. It doesn't necessarily have to be an ophthalmologist. There can be an optometrist as well who takes part in the care. But I think an annual exam after, at a certain point when you're thinking about getting the cataracts out or doing cataract surgery around that time, getting an annual exam is not a bad idea, especially if you have those risk factors we talked about earlier in terms of lighter skin pigmentation, family history, especially diabetes. It's mandated. It's one of the things by the American Diabetic Association. So, an annual exam is a good idea. Go ahead.
The color of the eyes make a difference?
Yeah, lighter pigmented irises.
Like light blue?
Like kind of like your eyes. Go ahead.
I just have questions when asked it. I've had close angle glaucoma and they've done that. Now they're watching for the other thing. I had drawing afterwards, and now it says they're getting the bubbles in that line that show.
Mm-hmm.
So now he's watching for that. Is it just a natural progression to go from glaucoma to the other?
Well, I don't think in terms of the glaucoma, I think that's a separate issue. So the closed angle and open angle glaucoma, sometimes they have combined mechanism glaucoma, where you have both open angle and closed angle glaucoma or components of both. If you've gotten lasers for the closed angle glaucoma, then that's usually no longer an issue. So once you get the laser done for the glaucoma, the reason why we do lasers, or I used to do, but I'm a retina specialist now, I used to do lasers, is because doing the laser will basically make the chance 0 of going into an angle closure attack. So that's the reason why you've had the laser. In terms of glaucoma itself, there's not a huge connection between closed angle and open angle, but patients can have both at the same time. Now, from going from dry to wet macular degeneration, there is a risk of progression, but it's not a natural risk. It's not like everybody, it's not a lockstep. It's not like everybody who has dry will obtain wet. In fact, the majority of patients with dry never actually go to wet. So. No. Sometimes you can get the choroidal neovascular membrane, and that can be the presenting symptom. So you could have, the first time it's noted can be the wet form. I've seen patients where the first time I'm seeing them, they've never been told they had macular degeneration before, and they have wet macular when I see them.
Could you repeat what you said about
Avastin? Yeah. So actually, that's an interesting story. I'll tell you if you guys, we have a little bit of time. Avastin is a drug that was originally developed by Genentech. And the story is actually pretty interesting because they developed the drug for metastatic colon cancer, so a completely different indication. And in 2006, down at the University of Miami, a retinal specialist by the name of Dr. Rosenfeld, Philip Rosenfeld down there, he was seeing patients who had wet macular degeneration and metastatic colon cancer who had been treated with the Avastin systemically. And they actually found the macular degeneration to get better with the systemic treatment of Avastin. And so at that point, he kind of made the leap into thinking maybe I can use Avastin systemically in my patients with just wet macular degeneration and see what happens. And so he started to do that. He took a few patients who had wet macular, who did not have metastatic colon cancer, and did a chemotherapy, basically, an infusion of Avastin for like a systemic dose of Avastin. And he found that patients actually got better with Avastin. The macular degeneration got better with the systemic dose of Avastin. And then there was another leap made, which was instead of giving the whole body Avastin, why don't I just give the eye Avastin by injecting it into the eye? And so he went ahead and did that too, and they found amazing results, kind of like the picture I showed you with Lucentis. Now, at the same time, the drug company that was making Avastin, which is Genentech, they were also developing, because they kind of figured the same stuff out around the same time he was figuring it out, and they ended up developing a second drug called Lucentis. So it's the same company that makes both, but they made a second drug called Lucentis that was just a smaller portion, but very similar to the drug Avastin. There's another antibody, but it was just a fractional antibody component. And they did trials with that drug, and it was very efficacious, as we talked about. And so they actually sell both Avastin and Lucentis. But the difference is that they sell Avastin based on the dosing for metastatic colon cancer. And so the drug itself is actually much, much, much less expensive, for everybody, for me, for you, for everybody, per dose than it is for Lucentis. The price for Lucentis per dose for the eye injections is about $2,000. And that's not what you pay, but or what anybody pays who gets the injections, because Medicare usually picks up a large portion of it. And a second portion, at least my patients, I try to get them assistance if they need it, and they usually do. But that's not coming to the Springfield Clinic or the doctors involved. It's going straight back to Genentech. And they also have the dose price for Avastin is about $50. But the difference is that Genentech won't sell us Avastin directly. They will only sell it to compounding pharmacies to compound the drug into smaller aliquots. Now, what's the problem with that? The problem with that is that there have been certain outbreaks of diseases because of the compounding pharmacies. You guys have heard about probably the New England pharmacy with steroid that was injected into people's backs that caused all kinds of infections. You may have heard that. That was about 1.5 years ago. With Avastin, the same things happened. It was a little bit further along ago in time, but with Avastin, there was a case in UCLA at their VA system. I think it was the Harbor VA, where they had 4 or 5 veterans who were injected with Avastin, or what the physicians thought was Avastin, but it ended up not being Avastin because of the compounding pharmacy. Whatever they put in that vial was not Avastin. And it ended up blinding those 4 or 5 veterans. And down in Florida, there was a second outbreak of, I think, a bacterial infection in a group of 15 or 20 people. So that's the hesitancy. That's what they don't tell you when you just read the prices and you think, oh, well, the price of this and the price of that. It's really the issue is Genentech. If Genentech would sell us the drug directly, then there would be no issue using the drug because we're getting it directly from the company. But there's a second step in there. And it doesn't happen often, but there are cases where we can be injecting something we think is the drug, but it may not actually be.
So when you say sell us, are you at the Springfield Clinic or us, everyone?
They won't sell everyone. They won't sell it directly to the physicians. They won't sell the drug in the small aliquot. Genentech won't sell anybody the drug.
So if our father is getting a Avastin from an injection, there's a wet macular degeneration, getting a compounded, which means he might be at risk on else, but it may not be cured Avastin.
That's true. That's true. Now, that being said, I use Avastin too in some patients, but it is a compounded drug. There's no way you can get it that's not compounded.
Because I know when our father's been having injections since past November,
Mm-hmm.
and they've been increasingly, first he did it once a month, well, 1 month, and then it got extended to 6 weeks, where now he's at about 9 weeks.
That's great.
And the improvement has been shown dramatically because
Yeah, you saw the OCTs. Yeah.
yeah, it was going. And I know that the doctor said after the first injection with the he said, well, come back in a month, we'll see what it's doing because there are other drugs that do get the vaccine not working. But since that was
Working.
he's still keeping injecting our father with the vaccine.
I don't think that's necessarily wrong. If he's showing response to the drug, that's fine, but it is a compounded drug. So that risk is very small, but it's there. So it's not wrong. I have patients that I treat with Avastin once a month. People in their, usually it's patients who don't have macular. They have other diseases that look like macular but present in younger ages. So like, other reasons but the same kind of issues. And so I can't use these drugs and I use Avastin. But I do let them know that it is a compounded drug and that isn't one of the other risks. Just like those other, there's always a risk of infection. There's always a small risk of stroke. There's an ongoing need for injections. And the third one with Avastin is it's compounded, so it's just that risk of infection or anything else is increased just slightly, but it is there. Mm-hmm. Yeah. 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 Mm. Yeah. I think it's fine to use it. I think if he's been responding well to it, there's no reason to necessarily change. To be honest, I probably wouldn't change him if he ended up coming to see me at some point and I knew he was responding well to Avastin. I probably wouldn't change because it's like, why change something that's not broken? But I would tell you when I saw you that it is a compounded drug and that's one of the other risks. Now, there's probably 1 million injections done a year in the country with Avastin. About half the injections in the country are Avastin. And we're not getting a large amount of those cases, but they do exist. It isn't approved by the FDA. It's an off-label indication. Genentech, because Genentech has never, they've never asked for FDA approval. That's the reason. Yeah, because they would undercut their other drug. That's why they've never asked for FDA approval of the drug.
So if it's off-label, is Medicare cover it?
Yes, in general they do. And the reason why is there was a big trial called the CATT trial, C-A-T-T. It was published in the New England Journal of Medicine. It compared Avastin to Lucentis. And on a monthly dosing schedule, they're equivalent for macular degeneration. That's another reason why it's fine to use Avastin. But it's just something that patients should know when they start getting injected, what exactly they're getting. I try and tell my patients, and a lot of times the conversation can be quick because we have so many patients to see, but I definitely try and go over with them what they're getting injected in their eye. And that's part of the reason why I really don't use too much Avastin, but having said that, A lot of people do, and it's a good drug. I've used it before. But the issue is that Genentech is unwilling to sell it in the dosages that are required for the eye. Well, all right, guys. So we got into a lot of different conversation. So thanks a lot for coming out here. And I hope you had a good time, and hope to see you guys again. So thanks so much for your time.
Yeah, very